In terms of, now there's even products now being marketed for vaginal sort of health and elasticity. They're doing, we know about the benefits of hormones and estrogen in particular on wrinkles and fine lines and skin elasticity. There's now, I do advocate for that. The benefits of estrogen in the vagina are real and profound. So with aging and menopause and the decline in estrogen levels, there's decreased blood flow to the whole genital area, which results in decreased elasticity and compliance, decrease in the collagen and smooth muscle fibers, so that the puffy 3-year-old cheek gets deflated. There's decreased arousal and lubrication. I wanted to show that. I'll go back to that other slide. Hang on one second. I'm having this is lubrication. Vaginal lubrication is almost like sweat. It's a transudative fluid. It's not like, there is secretions that come from the cervical glands, Bartholin's glands, which are in the labia, and Skene's glands around the urethra. But really what it is like raindrops across the lining, the mucosa of the vagina, like a pressure gradient. And that's due to blood flow. So anything that decreases blood flow, like aging and menopause, can decrease vaginal lubrication as well as engorgement. When a woman becomes aroused, the clitoris becomes engorged and the labia become engorged during stimulation and arousal. This slide, I like to show this slide. This is the clitoris right here. And what's interesting, what I like about this is that there's way more to the clitoris than meets the eye. The arms of the clitoris, these are their crura, they're called the cruras, go all the way down and attach beneath the pubic bone. So this whole thing gets engorged with sexual stimulation and arousal. And there really is no function of the clitoris other than for pleasure. And it is the homologue or the equivalent of the glans or the head of the male penis. This is when we were doing studies back when in research showing you the blood flow. See, this is a duplex Doppler ultrasound showing you the blood flow to the clitoral area. We were doing studies pre and post stimulation, measuring genital blood flow, clitoral blood flow, labial blood flow, and vaginal blood flow at baseline, and following stimulation with and without hormones, with and without blood flow enhancing agents. This is back in and then just real quick, I wanted to show you the risk factors. What are the risk factors for sexual function complaints in women? Aging and menopause, hands down, is the most common. Medications, high blood pressure medications, cholesterol lowering medications, hormonal contraceptives, birth control pills. A lot of young girls experience low libido and vaginal dryness on birth control. All of them. There's not one that's better than the other. Surgery, any sort of pelvic surgery, vaginal surgery, obviously chemo and radiation therapy, autoimmune disorders, inflammation, okay? And it's not just inflammation in fibromyalgia and in the bowel. Inflammation affects the whole body, including the genital area. Dietary and nutritional deficiency, especially B complex vitamin deficiencies, can lead to sensation arousal and orgasmic problems. And finally, I keep my favorite one, chronic stress. And I used to think, not everyone has chronic stress. I think everybody is chronically stressed, unless we do things to minimize and reduce it. So what are the medications that you are taking, your husband's taking? By the way, these same things affect men that affect sexual function complaints. Some of the diuretics, all of the SSRIs, basically, antidepressants, SSRI, tricyclics, cardiac drugs, beta blockers, hormonal contraceptives, again, steroids. Some of this other things that treat peptic ulcer disease can also, this is mostly for older people, but also male patients, the husbands of you that may have erectile dysfunctions. The same things that cause erectile dysfunction in men, by the way, cause sexual dysfunction in us. So now this is, I guess, some of these slides are I kind of pulled from different places, but another common problem or common association with sexual dysfunction is pregnancy and postpartum. And what happens, I say there's nothing, probably people, the doulas in America scream at me, but I say there's nothing natural about natural childbirth. There is, why ruin a perfectly good vagina? I delivered a 9-pound, 8-ounce baby. The first one was like a watermelon, and I saw on the doctors the other day, they did this show. Again, this is an LA thing. Have you heard about on Twitter, the Gap? Do you know what the Gap is? The thigh gap, they know. Okay, so I do not have a thigh gap, and I don't consider myself overweight. The thigh gap, which is a sign of beauty and thinness and prestige, is based on your anatomy, so your bone structure. So women that have wider, have the thigh gap. So, but I don't, and I had a 9-pound baby. So women that are like this, that's beautiful. Maybe it's anthropological, because you're more childbearing if you're wider. Like, I have no idea, but mine, I had a baby, so the shoulders, it was a nightmare. So the second baby, I had an elective C-section, and this was before the day. Now you can choose to have a C-section, the doctors will do it. Back then in 2003, which wasn't that long ago, you could not choose to have an elective C-section. It wouldn't be covered by my insurance unless I had some major medical risk factor why it had to be done. And I finally, so I had this whole debate. I got on Good Morning America. I was all saying that women should have the right to choose. We can choose whether or not we have a baby. We should choose how we want to have a baby. And then they were saying that there are health benefits to vaginal delivery, that, because it compresses the lungs when the baby comes out. And then the risk to the mom or God. Anyway, 10 years later, they found that if it's an elective C-section, not an emergency C-section, I agree with, but an elective C-section compared to vaginal birth, there is not an increased risk to mother or baby. And that took a long time. But by the way, the prolapse part of it, when after pregnancy and delivery, no matter how you deliver, C or vaginal, you are at risk for cystocele, uterine prolapse, enterocele, which is small bowel prolapse, especially the more babies you have, and loosening or widening of the introitus. So women will say it feels loose, it feels too big, and the area. So if this is your vagina and this is the anus, the urethra is up there. So the vagina, there's a separation normally when you're young. And these girls, they have a separation between that and that. But after babies, it this gets narrower. You probably all know what I'm talking about. The vagina is here, and the anus is right here, and that perineum is absent, and that leads to a feeling of looseness and wideness. Now that, where we were talking about the vaginal rejuvenation, they call that a posterior repair or a perineal repair, to recreate the normal angle, the banana-shaped angle of the vagina. I do advocate for that, and I do agree with that, because that, to create normal functional anatomy rather than aesthetic issues. So if you are experiencing loss of libido, diminished arousal, pain with intercourse, what sort of workup is done? And I put all these labs down. This is the full hormone panel that I request, and because we're looking at adrenal gland function, because what happens with chronic stress is, for a period of time, the adrenal glands can compensate for a while to maintain hormone balance. But if it is chronic and over time, the adrenals get fatigued. And when that happens, then that's when cortisol levels change. Cortisol is what causes the increase of fat around your middle section. The sensitivity of the insulin receptor changes, so we metabolize fats and sugars differently. When cortisol levels rise, cortisol, by the way, is the stress hormone. And when cortisol levels rise, serotonin in the brain falls, so we become more moodier, and epinephrine and norepinephrine rise, which are the fight or flight hormones. So even if we're not feeling particularly like running from the wildebeest, our bodies are in that fight or flight state. And when cortisol is rising and we're epinephrine and norepinephrine rising, our body is in a state of inflammation.
I'm Jennifer, I'm 40, and I love my Botox.
I love not seeing those lines anymore.
I'm in and out in about 20 minutes.
You can tell there's a glow in their face.
I don't feel 60, I don't look 60, I feel great.
I love it here at the Skin Center.
Bye-bye crow's feet.
Find your own beautiful at Pennsylvania's #1 Botox provider, the Skin Center, with one of our introductory express offers starting at just $99.
I'm aging beautifully.
The Federal Health Insurance Marketplace is now open. That means you're free to shop for the health plan that's right for you. UPMC Health Plan has some of the most affordable plans on the marketplace. And they all give you full in-network access to UPMC, plus other doctors and hospitals in your community. Visit upmchealthplan.com or call 1-855-297-UPMC to learn why so many people have chosen UPMC Health Plan. Enroll today.
The other thing, so the FSH and LH, adrenal gland, estrogen, progesterone, and testosterone. Where is that? Total and free testosterone. Thyroid function. So as ovarian hormones decline, adrenal function starts to go into overdrive, overcompensate. The thyroid, also the whole pituitary neuroendocrine axis, they're all interrelated. And what happens when the women go to doctors or in the managed care setting, you're on the 15-minute clock, that what they'll do is they'll say, well, all your labs look normal. And granted, a normal estrogen, if you look at what's normal, it's 200 to 400. So if yours comes back 30, that's technically normal, but that's not necessarily normal for you. And so the way that we're shifting is that the treatment is individually tailored to meet each woman's needs. So you might need an estrogen level of 220. She might need an estrogen level of 80 to feel good. So the hormones are a baseline, and we treat the symptoms. So if you're having perimenopausal symptoms, may or may not be having hot flashes. Some perimenopausal women who are not menopausal are having not usually hot flashes, but night sweats for sure. They are candidates for hormone replacement therapy. We are treating women that are not menopause with hormones to create balance. We are treating non-menopausal women that are having severe PMS with bioidentical hormones to help balance. PMS, what happens during PMS is it's not necessarily there is a fall, but it's the up, down, this that causes the highs and lows, that causes the mood changes, the bloating, the weight gain, and the other symptoms.
What if you don't have that baseline, like what your normal estrogen level should be?
Well, a lot of us don't. You don't know what you were when you were 30. So we go now. So we'll see what your levels are now, where they fall, and then what your symptoms are. So usually, if you're not on hormone replacement therapy, anything less than or equal to 80 is in a woman your age can be technically low. So you may need to be at 120. Another woman may need to be at 40. So if you don't have your baseline, we use whatever you are now as your baseline and go and treat. Okay, so. Talking about that, so who is for hormone replacement therapy? We want to know who is the ideal candidate. What are normal levels? Normal levels are the same. It's sort of the same issue as I like horses, she likes scrapbooking. It's individually defined and individually tailored. So when your doctor says your levels are normal, you say, well, that's not normal for me, and I feel that medicine has become very consumer driven. So if you're not getting, Vonda alluded to this earlier, you've got to find a physician that's in line with your goals and your advocacy and your action. And if you're not getting that, the guy says you're normal, go drink a bottle of wine or take a vacation and hope your libido gets better. I encourage you to find another doctor. Can hormones improve sexual function in women? We've answered that. Both estrogen, progesterone, and testosterone, and they work in conjunction. Estrogen helps with the blood flow, the lubrication, memory, mood, sleep. Progesterone is also really good for sleep and balances out estrogen. Testosterone is critical and works in conjunction with estrogen. They both need to be replete for libido. and energy, not only physical energy, but emotional energy. Like, let's go to the gym, let's go to, like what getting rid of Diet Coke did for me, like the testosterone, that's the test, it increases lean muscle mass versus fat mass and metabolism. What are the short and long-term risks of hormones? Those are questions that you need to understand and know. What hormones are recommended? What about SERMs? So SERMs are serum estrogen receptor modulators. It's not estrogen, they're estrogen agonists, meaning positive and antagonists. There's a new one out in the market that just got FDA approved called Osphena, and that is FDA approved for vaginal pain and dryness in women. Now, this would be an ideal drug for a woman that's not actively going through menopause, hot flushes and night sweats, but that's postmenopausal. I do have some perimenopausal on this medication that have chronic and recurrent vaginal pain and vaginal dryness and vaginal tears, but it's really ideal for a woman that's postmenopausal. So what are the non-hormonal options that are over-the-counter products, supplements, SSRIs? These are things that, remember I told you earlier, we do not have, that Osphena is the only FDA-approved treatment, and that's for pain and dryness. Things for arousal and orgasm and libido, we do not have any FDA-approved treatments. DHEA is an over-the-counter supplement. I talked to you about the adrenal fatigue. This is, DHEA gets converted into a weak estrogen and weak androgen. This you can get over the counter at CVS, Rite Aid, Whole Foods, wherever. They have done studies, placebo-controlled studies that have shown that DHEA in perimenopausal women helps to improve parameters of libido, arousal, and orgasm, as well as mood. In terms of medications, these are medications that are FDA approved for men, but we use them off-label in women to improve arousal. Sildenafil is Viagra. Vardenafil is Levitra, and then Cialis is the third one. Cialis is now even being taken on a daily basis for men to improve erections, and in women, lubrication arousal. Prostaglandin, which you may know, some of you that had babies, it helps to contract the uterus, but prostaglandin helps to improve blood flow. And there are two pharmaceutical companies that are developing prostaglandin gels to improve lubrication and arousal in women. These are things, apomorphine is, these are, how it works within the central nervous system. Dopamine improves orgasm, so that this is coming down the road. I'm putting these things out here so you're aware that things are in the pipeline. We're not being left, we're behind, but we're not being totally left out. Oxytocin is secreted during labor and delivery. But it also is dopamine driven and helps with orgasm and arousal. This is you can get this online. It's called onforher.com by a company called Sudsuva. This is an over-the-counter product that helps with genital sensation, clitoral in particular. It's a botanical oil. And I recommend this to patients. This is not an answer or the magic blue pill, but it does help women that are experiencing diminished sensation, and it helps women that aren't experiencing diminished sensation. And it's not like a hot or a cold Altoid. It's actually like a buzzing, tingling sensation that it creates. Now there's more vibrators around. This is something, I like this one because it can be used by the couple during intercourse. We talked about vaginal orgasms and clitoral orgasms. This is called the WeVibe. I wanted to put, this into, I'm not a relationship therapist or sex therapist, but how we feel about our partners and how the quality of our relationships obviously, is critically important. And men feel like men are intimate with us when we have sex with them. We feel like having sex with them when we feel emotionally connected. So if for whatever reason we are not having sex with them, be it due to pain, or be it due to dryness, or be it due to stress, or be it due to fatigue, they become less emotionally available. They're at work more, they're playing, not because they're bad people, but it's just the way it is. And then, it can become a vicious cycle and the relationship can go in crisis, which goes back to, why Oprah says just do it. You remember? Do it whether you want to or not. So these are things, to arm yourself with tools when you go to your healthcare providers, what you want to know, what you want to think about. Am I at risk for sexual function complaints down the road? By the way, we all are. You want your doctors to be accessible and have information and evidence that's evidence-based. You want to know what treatment options are available to you, not have a glass of wine and go take a vacation. You want your doctors to be informed and open and receptive. We are taught if we don't ask, patients won't tell. I'm telling all of you, tell, bring it up, and if you don't get the response or reception that you need, find another healthcare provider. You want them to be aware of your partner issues. You need to be aware of your partner issues. Sometimes when men withdraw from sex, it's because they are having, issues, either performance issues. Men go through menopause and andropause as well. Stress affects them too. So be aware of your partner issues. This slide I wanted to put out. We want this idea. We want to be cathected, and these are butterflies having sex. We want to be cathected and connected and intimate and have that absolutely perfect experience. Sometimes it may be, sometimes it may not be. But what made me think? I already had this slide, but I was reading on the plane. Have you read Proof of Heaven? Anybody here? I urge you to all read it. It's by a neurosurgeon named Eben Alexander, and he had he went into a coma and had a near-death experience. And he talks about being, he was on a butterfly wing. Anyway, it's an interesting book that talks where we were saying about mind, body, and spirit. For me, that book is what sort of crystallized the whole thing for me. And it's a layperson's book. It's not a medical book, but it talks about sort of dimensions that we don't necessarily see, coming from having an element of faith and hope, and carrying out our lives in a proactive way, in a different way.
Thank you so much for joining me this week for this episode of Hot for Your Health. You are a powerful force in your own health, and I'm excited that you took the time this Thursday to learn more from our nation's authorities in health. I hope that you subscribe so that you don't miss one single episode. Join us next week for Hot for Your Health, and for more information, find it at womenshealthconversations.com.